outcomes. And today we will be hearing from Mary Black Foundation, something about what they can share us about how they are achieving health equity outcome before and also after post-COVID. I just wanted to kind of bring out a little bit about where we will be hosting this webinar once it's actually done today. And I will actually let Haley and Keisha and Natalia to tell a little bit more about Mary Black Foundation. Just to kind of draw some of your housekeeping for you, you can ask any questions that you would like to at the end of this session. We will actually be answering them live as well as actually afterwards. There are some good resources over here that you would like to probably look at. And I will give it to Haley and actually welcome Haley and leave Natalia and Keisha to the webinar.
Hi, good morning. Actually, I'm going to kick us off this morning for our presentation on our health equity framework. And a sincere welcome to all who are joining us live, and then also those who will be joining us in the future via recording. Thank you to SOPAC for this opportunity for us to be able to share what our work has looked like in the space of health equity, in hopes that it will be of value and supportive to others' work across the world, essentially, based on what the participant list was looking like. So thank you very much. We'll start off with some quick introductions of who we are, so that you'll know who's presenting and sharing the content with you today. And I'll start with myself. My name is Keisha Gray, and I am the Program Director for Early Childhood Development, which is one of the 2 focus areas of the Mary Black Foundation. I've been here with the foundation, I'm in my 5th year, and enjoying every minute of it. And I'm really committed to this work because I have this fundamental, strong belief in the potential of humanity and the impact that philanthropy can have in moving us toward our shared best selves. So that is what keeps me grounded in this work, and why I continue to do the work with the foundation. My pronouns are she, her, and hers, and with that, I will pass it on to Natalia.
Thank you, Keisha. So hello, as Keisha said, my name is Natalia Valenzuela Swanson, and my pronouns are she, her, hers. And I serve as Program Director for Healthy Eating and Active Living here at the Foundation. Similar to Keisha, we're similar in timeline at the Foundation. I've been here for 5 years. And as far as what compels me to do the work, there are 3 values that guide my life, and one of them is justice. And so for me, that there are people in our community who are not able to live their potential and live healthy lives because of structures and forces that we collectively have set or that we perpetuate is an issue of justice. And I'm compelled to do this work to create a more just community for all. And with that, I'll turn it over to Haley.
Thank you, Natalia. My name is Haley Wicker, and my pronouns are she, her, hers. And similarly, I have also been with the foundation for about 5 years. And I am the Manager of Communications and Organizational Learning, and have been in this role here at the foundation for about 2 years now. And what drives me to do this work is that I've always been interested in health and well-being, and it's just such a great privilege to be able to work for an organization that is dedicated to that for every member of our community. And so with that, I am going to go ahead and start leading us into who we are as a community. The Mary Black Foundation primarily just serves Spartanburg County, South Carolina, in the United States. And so this slide here kind of shows some background information taken from our most recent census data, that our population is about 319,000, And we do have pockets of city, but we also do have a lot of rural area as well, with the median income of about $50,000. And then I'll let you see the racial composition made up there. And then a fun fact about Spartanburg is that it is an international business center with the highest per capita foreign investment and world-class international business firm here in South Carolina. So we do have a lot of international business, and it's just a great place to be. And for anyone with geography, we are in South Carolina. We're kind of surrounded by Cherokee, Union, Lawrence, and Greenville County, and that's us highlighted there in red. So moving on to a little bit more about the Mary Black Foundation itself. The Mary Black Foundation believes that health and wellness are basic human rights. And normally our focus areas are healthy eating and active living, as well as we have a community health fund that allows us to fund outside of that. Right now we're in a little bit of a pivoting situation due to COVID-19 and focusing on areas outside of that. But those are our normal focus areas of healthy eating, active living, and early childhood development. A few years ago, our leadership decided that health equity was a very important piece of health and should be what we incorporate into our work. So we did create a statement about health equity, and that was going to be something that we strive to achieve. And then last year at our board retreat, our staff or our board said that that was a great thing that we had this statement, but that we needed a concrete framework to help guide our work. So that is going to be what we get into later on in the presentation, what that framework looks like. But we decided we needed a framework because it does guide us in achieving our mission to invest in the people and communities for health, wellness, and success of our county. So I know today's call, we are focusing on the third sustainable development goal of good health and well-being, but just to give a little bit of context, that just because we are a health foundation does not mean that we just are in that one bucket area, that in fact we are in multiple areas, whether that be through advocacy, partnerships, technical assistance, impact investing. We kind of are in a lot of those different realms, which we'll get a little bit more into detail later on once we actually touch on the health equity framework. So I'm going to pass it to Keisha.
Thank you. So as Haley shared, our trustees made a commitment back in 2018 to really focus on health equity as a means of getting us to the fulfillment of our mission, which is good health and well-being for all citizens of Spartanburg County. And in order for us to do that, we needed to develop a framework that we'll share with you. But in order to get to the framework, we needed to understand exactly what health equity meant. And one of the tools that we used and spent a lot of time in building our own understanding and capacity a tool for us to be able to use to be able to begin to address really, really complex issues that our community was facing. And for these purposes, achieving health equity. So when we started to explore systems thinking as a way for us to dig into how we can bring some resolve to our efforts to become a much more equitable community, the first thing that we looked at and one of the first resources that we relied on was a tool of 14 Habits of Systems Thinkers, which was developed by the Water Center for Systems Thinking. And so there were 14 habits that really looked at you as an individual and how you approached your work and the way that you thought about the work that you were doing. And there were 5 key kind of cornerstone principles of the 14 that definitely resonated with us. And so all 14 are important, but if you decide to use systems thinking as a tool, there's 5 key things that really drive the work and must be the frame of mind and the lens through which you approach any changes. So the first is to first seek to understand the big picture, which is not always natural to most people. So being able to start there where you're saying, I'm not just going to look at the one piece that is most affecting me, but what is the larger picture, and being able to take a step back. The second is to consider an issue fully and resist the urge to come to quick conclusions. The third is to understand the system structure and to identify possible leverage points and actions. So again, as you're able to look at the bigger picture, not quickly move to action, then that allows you the time to spend in examining the larger system as a whole, and then finding those points that can really create the best outcomes when you use them as leverage points. The fourth area is to consider short-term, long-term, and unintended consequences of actions. So before you move to the whatever solutions you've devised, to then ponder on those a little bit more and say, if we do that, how can that affect other parts of the system immediately and in the long term? And then finally, which is typically the hardest part to do, is to consider all of the mental models that affect current reality and the future. We know that policies and practices are infrastructure, and they're concrete things that guide the actions of others and of ourselves. But our mental models, the way that we think about the world, the way that we view the world, really does shape the way that we create those policies and practices. So being able to tell the truth about where we are and the way that we see the world individually and collectively is important when you're deciding on the way that you're going to create resolve for issues that you're dealing with. So we started with those and started with dealing with our own selves individually and creating those habits within our work as professionals. And then started to dig a little bit deeper into the understanding around systems thinking. And so we wanted to give you a full definition of what systems thinking is. And essentially, it's a holistic approach to analysis that focuses on the way that a system's constituent parts interrelate and how systems work over time and within the context of larger systems. The systems thinking approach contrasts with traditional analysis, which studies systems by breaking them down into their separate elements. So it's a much more holistic approach. It is not a quick fix to anything, and quick fix is a common systems thinking terminology. So if you ever decide to get into it, you'll definitely hear the term quick fix. So write that down and hold that, put a pin in that if you decide to use this as a tool later. But really systems thinking allows you and gives organizations and communities the permission to move methodically and thoughtfully in creating the resolve that can have long-lasting positive change for them. So our health equity framework is really an application of the systems thinking approach. And when we moved through thinking about the framework and developing the framework, there were a couple of things that really the systems thinking approach really allowed us to do. So the first is that it helped us to recognize hidden and unintended consequences of the current state of our health equity as a community. So it allowed us, again, that time to sit back and really examine everything and every aspect of what is and isn't helping us to move towards health equity. The second thing is it enabled us to think deeper and wider about effective strategies in this complex system of health outcomes. It was helpful when we considered strategy and change, again, to be thinking about the short term and the long term. And then finally, it expanded the choices that we had available to us and enabled us to focus on higher level leverage strategic interventions. So not spending your energy and resources on things that may be good, but may not create the impact that you ultimately want to see. So by taking the time to sit with the issue, look at it thoroughly, we were able to identify those leverage points, which you'll see reflected in the framework, that if we're able to make change in those areas, it will really accelerate the type of impact that we'll want to see in our community. So that was the process and kind of the thought process that we went through in order to move towards our health equity framework. Haley mentioned earlier that in 2018, the first part of 2018, our trustees did put out our official health equity statement. And the community responded really, really positively to it. It felt right, it sounded right, it was something that resonated with everyone. But the community also said, well, what does that mean and how do you operationalize it? So we produced some materials and some tools that we made and resources that we've made available to partners to help them better understand what we meant by health equity and to better ensure that we were doing the things that would move us towards this vision of a community where all people could have access to opportunities to thrive physically and mentally, regardless of what demographic they represented. And so the first was to ensure that people understood the difference between equality and equity, because those are two terms that often get interchanged. And so when thinking about equality, it's creating an opportunity, right? If for this example, it's creating an opportunity for transportation for individuals, and the resource that we wanted to provide was a bicycle. Well, equality says, let's give everybody a bicycle. But clearly that single type of bicycle does not work well for everyone who would want to or need to use that as a mode of transportation. So equity says, yes, we know that everyone needs transportation. Bicycles are a resource, but the equitable thing to do using equity is to ensure that the bicycle is in the right format and it is in a way and provided to the individual in a way that makes it most useful and accessible to them. So that was one of the first things that we wanted to do to make that distinction. Then we started to ask ourselves, well, why? Why is it important for us to be doing this work? And when working with complex issues, one of the first things that we wanted to do is to answer that question for ourselves. We knew it sounded right, it felt right, but why should we be focusing on health equity to get us to the fulfillment of our mission? So the first thing that we explored was this understanding around health is not being determined solely by your personal choices, your genetics, or your culture or behaviors. So this allowed us to say, we've got some ownership and some responsibility in ensuring that our community collectively is achieving health equity, because it's not just about the individuals and whether or not they're making good choices or bad choices, or if they were born with the right or the wrong genetic makeup, but there might be something outside of their own controls that we can be helping to support that will help them get closer to the more equitable, positive outcomes that they would like to see. So that was the first thing that was really compelling to us and for why we wanted to center our work around health equity. The second was this undeniable data that, that we were seeing, and we were doing good work. We were making good investments in the community, but we were still seeing, as we started to disaggregate the data, that there was a lot of inequities and outcomes depending on the populations that we were examining. And so that stark inequities drove us towards saying we've got to do something about moving our work, thinking about our work, and shifting our work to ensure that we're providing the types of resources that will create greater positive outcomes more consistently across the full populace of Spartanburg County. So in thinking about that, the next thing that we did was we saw the data, we said we've got a responsibility towards it, but we still want to understand the work a little bit more. And so we looked to experts in the field to continue to help us to understand what health equity is and how we can achieve it. One of the first resources we looked at was the World Health Organization. And what they did was they defined it in three major categories. They said that health is determined by more than personal choices, genetics, or culture. But what it is determined by is the social and economic environment in which an individual lives, the physical environment that surrounds an individual, and then also the person's individual characteristics. and behaviors. So looking at those three, the personal choices, again, is only making up 1/3 of the way that we ultimately achieve or don't achieve the kind of health outcomes that we'd like to see. So that was intriguing to us, and we wanted to continue to dig deeper and gain some additional understanding around it. And so we looked at the Robert Wood Johnson Foundation. They're the largest health organization or foundation in the U.S., and they've been doing some work in the health equity space well before most organizations were even thinking about health equity as a means of bringing about greater positive outcomes for health. And so based on what they have provided, when they think about what predicts someone's health, 70% of health is determined by factors not related to personal choices, genetics, or culture, but other things that are determined as what we call the social determinants of health. So about 40% comes from your social and community context, and that's things like your education, job status, family, social supports, your income, communities, and the safety of your community. 10% is around your physical environment, air quality, environmental concerns, concrete things like housing and transit systems, your ability to get to and from potentially employment opportunities. And then 20% is really kind of made up of clinical care. So that's the level of access that you would have to the healthcare system. And then once receiving that access or choosing to access that care, what is the quality of the care that is received? And then that lower part, that 30% of what predicts your health outcomes is around your own, again, your own personal choices. So diet and exercise, tobacco use, drug use, sexual activities, those types of things. So if 30% of our health outcomes is based on the actual choices that we're making, and 70% is outside of those personal choices, then again, this is another way of looking at health equity, and another visual that compels us to move towards creating a framework that others can be partnering with us to change for our community. So then we continued, and this is just another way of thinking about that further breakdown. So the Robert Wood Johnson did it in 4 different compartments, and then looking specifically at the social determinants of health, there are 5 different ways to be thinking about those outside influences. And so social determinants of health are conditions in which the environment in which people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So we wanted to make sure that we understood what those things were. In the previous research and discoveries we were making, we heard about the impact of education, economic stability, neighborhood and built environment, and health care. But this idea of the social and community context was another layer that really deeply resonated with us. So it's not just about the infrastructure, but it's also about the way in which that infrastructure is built, and the way that the individuals that live inside of that infrastructure are interpreting it and interpreting their ability to really take full advantage of whatever infrastructure is available. So understanding around what that social and community context is another layer of understanding that we thought we needed to make sure that we incorporated into the framework. So in thinking about the data, that was the second big why for us. We thought we would share a little bit about some of the population level data that we're exploring and monitoring over time, because at the end of the day, what you don't measure, you kind of forget about, and you move away from it. So because early childhood development is one of our focus areas, there's 2 big indicators and trends that we follow fairly closely for our work. One is the infant mortality rate, and the second is low birth weight rates. And we've disaggregated that data, which is really critically important to anyone's work is it's not just enough to get the trend lines and to see what's happening with specific pieces of data that tell the story of how well your community is doing or how well the work that you're doing is impacting the outcomes that you want to see, but it's more important to be able to disaggregate that as well. And typically when you do that along racial and ethnic lines, and or socioeconomic lines, you get a very, very different story in the data and the trends. So specific to infant mortality rates and low birth weight, you can see that for our children of color in the low birth weight rate category, they're not faring as well over time as their white counterparts. And then in the infant mortality rate, African American and Black babies, which is represented by the blue lines, are not faring as well and than their white counterparts. But what is interesting to us and something that we continue to dig in is that the Black trend line is actually that of infants born to Latinx families or Hispanic families, and they're actually trending better than their white counterparts. And so the question becomes there, and what we're spending time in digging into because of this understanding about social and community context is why, despite all of the barriers, are Hispanic babies doing much better in terms of infant mortality? What is it about the social and community context of the prenatal space? What happens in the first year of life that really supports them in ensuring that they have really positive outcomes? And so rather than that being an area of despair and sadness for us as it relates to communities of colors, but it's a really beautiful bright spot for us that we can learn much more about how we may be able to incorporate that for other communities. And so with that, I'll turn it over to Natalia.
Thank you. So just to continue on what Keisha was sharing on data, on this slide, there are 2 data points. And so the one on the top is one of the key data points for us as a foundation in the work of healthy eating, active living, which is the other priority area. And this graph represents the body mass index of all 1st, 3rd, and 5th graders in Spartanburg County from 2013 to 2018. And it is also disaggregated by race and ethnicity. You can see it specifically shows the percentage of students who are overweight and obese. And you can see a trend that over these years, our Latinx or Hispanic students remain consistently on top, followed by African American students, and finally by white students. The second chart on the bottom is the percent of people in Spartanburg County living in poverty. And this is data, a data point not solely tied to the work of healthy eating and active living, because poverty impacts all of our work. Here, however, we do see an interesting parallel between the 2 data points, as the trend or pattern for poverty is similar to the trend for childhood BMI percentages. Again, with Latinx or Hispanic students and African American households next to be more likely in poverty, and then white households. So like Keisha was saying, when we begin to look at data, it begins to point to understanding the why behind the data that we're seeing. And so as a team, we did pause to observe the data, such as these graphs, and there were others that we've looked at and continue to look at. And we observed those patterns over periods of time. And when we do that, we're able to more clearly see that health inequities that we're seeking to address did not exist in isolation. So in this case, poverty is one of the co-conspirators of health inequity. And we cannot ignore that race has historically determined income, and therefore income inequality continues to be tied to race. And this is why it's so important to disaggregate the data to more clearly see our reality. So the next slide, whereas the 2 previous slides that we shared show 4 data points for our whole county, as we continue to dig deeper into the data, we notice some other trends. Here on this slide, there are 5 zip codes where pretty much no matter the outcome that we pulled, the results were worse than in other parts of the county. And so the 5 zip codes that are listed here, as you can see, are 29301, 29303, 29306, 29330, and 29372. They're all, again, in Spartanburg County. And you see them compared in 4 health outcomes and compared to our overall county rates and percentages. So in infant mortality, there's 1 zip code with a rate of 20.9 compared to the county rate of 4.7. And I'm just highlighting the stark inequities. In rate of babies born to mothers with less than a high school education, you see 1 zip code with a rate of 139.9 compared to the county rate of 85.8. In rate of babies born with low birth weight, you see 1 zip code with a rate of 128.5 compared to the county rate of 89.1. And then in the percent of children visiting the emergency department with a diabetes diagnosis, you see 1 zip code with an 11% compared to the county percentage of 3. So again, pointing out those inequities. And all of this data and the discipline of stepping back to really observe the data and the trends helped us decide where to focus our work. So our foundation has prioritized these 5 zip codes for our work. So we transition now from the why behind our work and our approach to the how. So we had the definition that Haley shared and that Keisha further explained, and the data that we just shared with you now, pointing to the need to focus our work. We spent time then as a team pushing to better understand the whole system, again, to apply those principles that Keisha shared on systems thinking, and researching best practices and evidence that helped us create our health equity framework, which creates really a vision for how we believe Spartanburg County will achieve health equity. So in the next couple of slides, I'll show and explain the details of the framework that has become a tool for us to advance health equity. And this framework guides us in how we use our resources as a foundation to advance the work. It's not just our grant making and impact investing, but it includes also our capacity building, technical assistance, advocacy, convening, and strategic alliances. As we continue viewing our work through a systems thinking lens, we recognize the critical value of all these different roles and resources. When we see the big picture of our system, we recognize that we can't do this work alone. And so that's where the strategic alliances become so critical of bringing others along to see the system and understand it. When we consider those short and long-term strategies, and we recognize the need to provide support to our community partners so that they understand how to carry out the work with those 2 perspectives in mind, and also being cognizant of the unintended consequences that come from our work. And then when we begin to make the connections between poverty and health outcomes, as an example, we recognize that policy change and therefore advocacy are also critical to advance health equity. And we use all of these resources to advance the work outlined in our health equity framework, which I will explain next. So our health equity framework is introduced through a context setting paragraph that you'll see on this slide. And this context setting paragraph is also our foundation's public statement or point of view on what our health equity framework means to us. First, the statement includes and begins with what we seek to accomplish. So on the first sentence here, the Mary Black Foundation seeks to increase the well-being of children, families, and communities, especially those disproportionately experiencing inequitable negative outcomes. What our research has shown are the structures and forces that can and have prevented people from accessing opportunities. So we recognize that individuals' ability to access opportunities is shaped by their social and community context, and inequities in access are often the result of centuries of unjust policies and structural discrimination. Policies and other forms of structural discrimination have largely shaped the social and community context. Consequently, when we approach our health equity framework, it's critical to first understand that social and community context, like Keisha was explaining, and the nuances there for different groups. And this is where we begin to uncover the complexity of the system. And finally, the context setting paragraph ends with our vision or our health our health equity definition. Health equity exists when all people have access to opportunities to thrive, both physically and mentally, and no one is limited in achieving health and wellness because of their race, ethnicity, nationality, gender, ability, sexual orientation, age, income, or zip code. So with the context that I framed, or our position statement, and together with research that we did, which showed that there are three things that shape our health. And those are where we live, or our zip code, our income, and our race. And underneath all these three, what the research was pointing us to was that the macro level driver for health was structural discrimination. So with that understanding, we then concluded that to advance health equity in Spartanburg, we will need three things. One, high quality education and employment. Two, safe and supportive neighborhoods. And three, accessible, affordable, and culturally relevant healthcare. These three make up our health equity framework, which is what you now see on the screen. And these broader categories are displayed, as you see here, as an interconnected system that all need to be present to achieve health equity. And within these three broader categories, or buckets as we call them, there are subcategories that define the buckets and what they actually entail. Before we move on to those specifically, though, I'd like to highlight again, thank you, that these three buckets are interconnected. So all three and all of their subcategories are needed in order to achieve health equity. We believe that as Spartanburg moves forward, all of these pieces will need to be in place to achieve health equity. And centered in all of this are the people. And for that reason, and perhaps of most importance, is that piece of social and community context that was stated a couple of times already. This is a lens through which we view the framework, because if a city or county has all of the items that we have here listed, the social and community context will actually dictate whether individuals and groups, communities are actually able to access it. And race and place create barriers to opportunities, and structural discrimination has created very different social and community contexts for different groups. So this diagram, while helpful to clarify and simplify into these three broader categories, at the same time, it reveals the complexity of achieving health equity, and systems listed here are so huge. And we recognize that we can't work in silos, and because one system is going to impact the other. And it points again to the importance of the strategic alliances. And we recognize as a foundation that we can't do all this work on our own, but we acknowledge that it is part of our work to fulfill our mission. So now we go into the subcategories within each of these buckets, beginning with a high quality education and employment bucket, which this includes everything from the early years, which many of us have come to acknowledge that plays such a critical role in development, and then on through the K through 12 education system, through opportunities for higher learning, into career readiness and job training, and then ending with employment, but with wages that allow for self-sufficiency. And here you begin to see some connections with those sustainable development goals that Haley shared earlier too. The next bucket is safe and supportive neighborhoods. And when we talk about safe and supportive neighborhoods, we envision neighborhoods that provide adequate transportation, clean, safe, and connected affordable housing, parks and open spaces where kids and adults can be outside playing and also connecting with each other, access to fresh, healthy food and clean water for strong bodies and minds, complete streets so that all people can navigate in their communities and not just those who have cars, and positive youth development opportunities that support thriving minds and bodies. And then in the last or third bucket which is related to healthcare. And the three descriptors here are key, that it be accessible, affordable, and culturally relevant, to really take into account the social and community context of different groups within our county. And you see, I'm driving that point just on the importance of that in how we do the work. We envision this type of healthcare that would be evident in spaces of mental health, maternal and child health, adolescent health, dental health, and also in the systems and procedures for screening, prevention, and treatment. And And so in all these buckets, we're working toward reducing the inequalities that we see so clearly and that the data was pointing. And so then I'm going to move on to the next slide. So once we developed our framework, we paused again to identify ourselves in the work as we had outlined it, not the other way around, meaning we didn't develop the framework to reflect what we had already done, but we truly developed it from what we learned through research on what it was that shapes health and what it was that we would need to attain health equity. So this slide, or the Health Equity Framework in Action, shows where we, the foundation, have already been doing the work towards health equity. The 3 categories and the 3 different colors correspond with our framework, those 3 buckets. Within the space of high quality education and employment, as you can see, there are a couple of examples. We've done work to build capacity and advocate for policy change in the preschool space. We've also provided training to educators and technical assistants to create healthier learning environments. And then you can see similarly in the other buckets, examples of other types of the works that we have done. I'm not going to go through each one of them just for sake of time. But above all, this was not so much about highlighting what we as a foundation have done, but more so to help similarly others identify where they fit in and where are they doing the work and where do they see themselves plugging in to help accomplish the goal. So the next slide. So as we wrap up on the how section of the Health Equity Framework by highlighting how we have already begun to use this tool, as we continue forward, just going to summarize with the 4 points. As I mentioned, it's about helping others see themselves in the system and the work of health equity. We hope this framework serves as a tool just for that, to engage partners, because the system is so complex and no single organization can do it alone. It's also a tool to help focus our grant making and prioritize our funding. The framework has helped create a vision of what we believe is needed to attain health equity. Those buckets and their subcategories are not enough to simply have available within the county. But we believe that it's necessary at a smaller scale, or specifically at a zip code level scale. We see that we would like to have all these categories in zip codes, and now we can prioritize our funding so that we can create these places that will foster and cultivate thriving and connected communities. And then it's also a tool that helps inform our decision making. Are the projects, ideas, and opportunities that come to us aligned with this vision? Do they fit? This tool helps us making those decisions on where we prioritize. And then finally, we really hope that it will truly catalyze advocacy efforts. Our systems have been shaped by centuries of unjust policies, and we will need policies to change our reality. And so this tool helps identify the areas and hopefully within that, the policies that shape those areas that may need to be addressed through advocacy. With that, I'll turn it back to Haley.
And so now we're going to get into how we have pivoted our work due to COVID-19. So when COVID-19 started here in South Carolina and started picking up, our leadership and staff kind of got together to talk about our grantees and our community, and we decided to make a few changes temporary to the situation to meet the needs of those people. And so a few things that we really struck with were suspending reporting requirements for a little bit, just because we knew that people were very overwhelmed with just getting the work done with increased demand for services and having to shift how you're working. It was just very apparent that asking folks to then layer on reporting was an unnecessary burden for the moment. We allowed our grantees to use some of their funding for needs that might have been outside of their original grant agreement, which a lot of people appreciated. We offered assistance through partnerships and through some of our own team's expertise to kind of help with some of the federal funding opportunities that were available. And then lastly, one of the biggest pieces that we did was just listened to those grantees. So our program staff called all of our current and former grantees to check in on them, because we wanted to listen and learn from them and see how we could help them in ways outside of just being a funder. So we asked them how they were doing as an organization and just on a personal level. We asked if their organization was going to be able to financially support themselves over the next 2 to 3 months. And then with that, if they had planned on applying for any of those federal assistance programs. We asked if they were going to make any programmatic changes to what they were doing to meet the needs of their clients. And then lastly, we asked them what their biggest concerns were, whether that be with them as an organization, for our community as a whole, or specifically to the populations that they serve. And so we kind of put all of that into a spreadsheet and looked at it and identified a few key areas of concern that we kind of lumped together over 25 different organizations, that their top concerns were concern for the families' housing stability once eviction moratoriums were lifted. They were concerned about seniors who may not be seeking services for fear of exposure to the virus, concerned about children who may be facing abuse or neglect, but that is going unreported due to the decrease in mandated reporters having eyes on children, concern for our Latinx community who might be fearful of accessing services and or not having access to or knowledge of supports being provided, concerned about how the virus is impacting African Americans more, and then concerned about students' educational and health lag. So we looked at all of that, and then while we were doing that, we were actually in the middle of a grant application. So we kind of paused and said, you know, normally we would be funding for healthy eating, active living, early childhood development, and our community health fund, but right now that is not what the priority is. So we are going to shift and just have this funding cycle be about COVID response. So we had folks, you know, withdraw applications, redo their applications, and we just really made it about that. And once we went through that application process, we then paused and said, okay, for our cycles going forward, let's be upfront and say that these are going to be our focus areas. So we identified 3 new buckets of focus area, and that was mental health, education, health lag, and just ongoing basic needs. And going back to that systems thinking, we do realize that there is a short-term need, that folks need money to buy supplies, for people to get help immediately, and that's okay. So we decided that we were going to have a short-term application that is strictly for those basic needs, that is right now, but then also a long-term application that would look at longer-term outcomes that isn't necessarily something we might see the outcome today, but it could still fall in that COVID-19 response, but just the outcomes are going to be a little later on. So when thinking about our health equity framework, we kind of looked at the 3 bucket areas that we have and pulled out some of the subcategories that were within those, while also looking at those concerns that everyone was sharing with us. And that is how we came up with those 3 bucket areas of education, health lag, basic needs, and mental health. And so conveniently, last year we had already gone ahead and created new logic models for our healthy eating and active living and early childhood development outcomes reporting, because we wanted those to be more aligned with our health equity framework. And so it was pretty nice that that was already fresh on our brain and had new outcomes that we were already going to be asking folks to report on. So thankfully with the SOPAC system, it was very easy to go in and edit what we were asking people to report on and make those pivots. And since we had already changed those and are going to be having this overlap with our health equity framework, we didn't have to make too many changes to our outcomes of things that we weren't already going to be asking people to report on. And so thankfully the system does allow those changes and has that bank of outcomes that we could reference. And that since we do have these multiple theory of changes that we are using within the system, that it still will allow us to look at those over time and aggregate them together to see the longer term impact. So with that, I'll turn it back over to Keisha.
Thank you. So we've shared a lot with you all. And so this is the point where you take out the pen and write vigorously to summarize all of what we said. So the first thing, and this is starting back with the first part of the presentation as a key takeaway, is this understanding that systems thinking is an approach that can be very useful and be used well as a tool for much deeper thinking when you're trying to address complex issues such as health equity or achieving health equity. So underneath that is first to start with yourself as an individual. A really good source of reference is the Waters Foundation 14 Habits of a Systems Thinker. And that really will help you to begin to recondition yourself in the lens that you use individually as you approach the work through a systems thinking approach. And then the next part underneath that is just a note about 4 key principles of systems thinking. And the benefit of using a systems thinking approach is that it helps you to recognize hidden and unintended consequences, supports your deeper and wider thinking about what effective strategies you might want to employ. It allows you to take the time to think about any changes that would happen in both the short and the long term. And then finally, to be very thoughtful about thinking about the higher leverage strategic interventions that will create the greatest impact with the same level of effort going forward. The next key takeaway is around the data, and we shared quite a bit of data that helped us to ground us in our work, and again, to understand why we want to remain committed to the work, but then also where, as we start to think about how to approach the work, where that work needs to be happening. So first, when you're considering the data, you want to know what data you have available, and if not, how you might be able to access more specific disaggregated data that tells a broader picture. And then again, break down your data, disaggregating it, and specifically racial and ethnic and socioeconomics, because those are often key drivers of inequities within communities. And then the importance of tracking your data over time so that you can see where trends are, look for where patterns might be, and then start to ask the questions about what was happening in that point in time. And again, to Haley's point, the SOPAC system is a great way for you to be doing that and collecting it, and then analyzing that data later. And then the third big key takeaway is around using this framework as an example. We hope that you'll go back and create your own frameworks. If health equity is something that you would want to achieve, we would encourage you to do that. It's a good way to engage not only your organization in thinking about how to move the work forward, but to create a call to action for others to partner with you. So if you decide to do that, the first thing is to recognize the complexities of addressing health equity. Utilizing a systems thinking approach is very beneficial. You'll also want to identify stakeholders that can help support your framework. And then thirdly, and probably one of the most important, is to recognize the assets of the communities that you want to bring about change in. Every under-resourced community is not simply disparate. There are multiple resiliency points within those communities and lots of strength. And your ability to engage them in authentic ways to better understand that social community context and help them to realize the strengths that lie there and use that as a basis point for building and creating greater equity is going to be critically important. So with that, I hope that all of this was helpful to you all. I think we're going to turn over to Lorena to share a couple of things, and then we'll take questions.
Thank you, guys. I'm just going to take 5 minutes here. So my name is Lorena Rodriguez. I'm the Customer Success Manager at SOPAC. And for those who are joining for the first time, we have a platform to exactly document or your theory of change, your outcomes, collect data from multiple grantees or other individual stakeholders, and process all of that to be able to track your outcomes over time. So we have been working with Mary Black Foundations. I've been working with Haley closely for about a year, in defining all the framework that you just heard about. Everything is on the system. So I just want to take 5 minutes to explain what are the in which ways Mary Black Foundation is using this platform, because we see often that you have questions about, okay, this is great, but then how do I make this actionable and start actually collecting data to see if my outcomes are improving or not. So the way Mary Black is using our platform is by first documenting the theory of change, like Haley was mentioning, the outcomes, and even the relation to the outputs and activities in the system, and define specific metrics for each outcome. And they also have the ability to present that list of outcomes to the grantee applicants. So now, for example, that they have this new COVID set of outcomes, they can just plug them into the system, and for the short-term and long-term application, they can just present those outcomes to the grantees. So they choose the outcomes that they are able to report on, and the metrics also that they can they have the ability to collect data on those metrics, because obviously not all the grantees will be able to collect the data for all of the metrics per outcome. So they give them the ability to choose which outcomes, which metrics, and those metrics are assigned to the grantees so that they can collect data every 6 months based on those metrics. That way they can track the results over time, track the progress, and even as the data is being reported by the grantees, Haley has the ability to see exactly who is in which step of the data reporting. So if she sent the survey to 10 grantees, she's able to see how many of them haven't even started reporting the results, how many are in progress, how many have submitted the data, and that allows her to, through the automatic reminders that we have in the platform, get the data on time. So she can, review the results and even start using the data for reports or create dashboards or whatever she wants to do with that data. So she's able to see, obviously, as the results come in, as the grantee starts submitting the results, she can see those results, review them. She's able to analyze the results by a specific grant or by a grantee across multiple grants, and also for a program. So across multiple grantees reporting the same metric. And the idea is to be able to create at the end dashboards, maybe per program, to track some KPIs that could be, here are some examples, could be like fresh produce distributed to marginalized communities, well-maintained parks, playgrounds, and other recreation facilities, receiving proper medical care and immunization, young adults receiving contraception counseling and other services. So these are a few of the key metrics, the things that will tell them if they are achieving the outcomes that they just talked about or not. And by collecting this data and by creating these dashboards, they can just keep those as KPIs and track them constantly. And the last point is, as Haley was mentioning, they are able to make improvements in the framework as they go. With this COVID-19 situation, she was able to just plug some new metrics or use the outcomes in a different way. Everything is very easy to configure in the platform. So for all these changes, she can just make the adjustments and keep collecting data for the normal outcomes and also for these short-term programs. So I just wanted to talk about that. This is just an example of how the data can be aggregated, in this case across multiple grantees, just to see the overall results for example, total people served in the healthy eating, active living program. And in this way, we can create multiple visualizations for any other relevant metrics, and we can also export these visualizations to plug them in presentations like this one, reports, or share them with any stakeholders as needed. So that's it from my side. And yeah, let's see if there are any questions. I saw that some of the questions actually, as the presentation was going on, they were answered at some point, like for example, related to the zip codes and some other questions. But I'll let Hetal speak a few that might be very relevant to ask live.
So thank you, Lorna. I think we're running out of time, but wonderful. I think it seems like so much learning about the system thinking, how health equity needs a deeper and wider digging into and understanding, and actually have to have a multiple SDGs align to achieve one. And I think some of the questions that I was reading through were answered. I think one of them was about knowing more about Impact Cloud, which Lorna did that. One of them was about how you were achieving the health equity through the zip code watch activities that you have. And I'm thinking that, some of the later part, I think you did kind of give a good presentation on that. One, I think, was also about this SDG alignments, like, why do you choose to align yourself to so many SDGs, even though you think that you're achieving health? And I think Haley spoke about that. So I don't know whether you have any thing that to add to any of those sentiments about the zip codes and the SDGs. Otherwise, I think we can close and thank you so much. I mean, this was actually so informative. I think I probably will have to go through many times to understand the framework really well. So I would actually let anyone say anything last.
No, I would just say thank you all for hanging in there with us for the last 3 minutes over. And if it's helpful, we're happy to put some of those answers in writing. And if there's a way for you guys to post that along with the recording, then we're happy to do that as well. So thank you for your time this afternoon and morning or night, wherever you are.
Well, thank you so much. Actually, we will be connected and I'll be sending the webinar recording as well as the slides to you. And feel free to ask any questions to us and we will have them answered as we go as well later on. Thank you all.
Thank you.
Thank you.